Hello, my dear doctor. Welcome to the topic ankylosing spondylitis. We call it AS. Once again, the KBA file means the knowledge-based application or question-based approach. You have seen there is the SS box that is given that you already have seen in your video lectures. Next is the question, alright? So whenever you have the scenario according to the question approach, the first step, always we go directly into the main question. Means what is the diagnosis? First step. And immediately after the second step, the reading the answer options. So what is that? Ankylosing spondylitis, psoriatic arthritis, enteropathy associated arthropathy, and Reiter syndrome, and chronic tubular arthritis. And third step, immediately after that, each and every options will have the SS box. So we'll think about the SS box. So now let's think about the third step for the SS box, ankylosing spondylitis. We learned the ankylosing spondylitis, the rule of A. Yes. Starting from the head to toe means starting from the eyes, then the lungs, then the heart, then the abdomen, then the arthritis, and then down to the legs. The findings, starting with the A for anterior uveitis, A means the iritis, which is a painful red eye. Then go down into the lungs, apical zone fibrosis, A for apical zone fibrosis. In a heart, aortic root dilatation leading to aortic regurgitation and leading to aortic dissection. And also in the heart, AV conduction and amyloidosis. And amyloidosis, whenever the topic they come up, that the restrictive cardiomyopathy, nephrotic syndrome, and hepatosplenomegaly. And in arthritis, is the axial joints involvement, especially the SI joints. Axial joint is named the ankylosing spondylitis, so the spine as well as the SI joints is involved. And also, because of the seronegative spondyloarthritis, we already learned another SS box that the SHA-D, that is once again the asymmetrical oligoarthritis, the typical variety. And sixth topic, there is a coda equina, a block, alright, block letter, alright. So another one is the plantar fasciitis. So these are the box for the ankylosing spondylitis that we need to learn. So immediately after the box, right, the third step, we will focus on to the fourth step, is the photography, photography. So focus on to the photography. So photography showed that there's an apical zone lung fibrosis. So there is an apical shadowing. So apical shadowing, once again, means apical zone fibrosis, only A for apical, A for ankylosing spondylitis, and also psoriatic arthritis can cause. But others don't produce apical zone fibrosis. But the TB, once again, have the lung fibrosis can be caused by the tuberculosis. So one photography that we have seen here. And immediately after the photography, the fifth step into the data, right? Fifth step into the data. So what data say that hemoglobin normal, WBC normal, platelets normal, ESR. Yes, this is 107 is raised. So once again, the inflammatory joints disease. Chest X-ray shown, rheumatoid factor negative. So once again, this seronegative spondyloarthritis. Seronegative spondyloarthritis. Once again, the ankylosing spondylitis. Axis of the left knee, soft tissue swelling, no bone involvement. Aspirate of the knee joints, yellow fluid, low viscosity, WBC is 50 per cubic millimeter, but the culture is sterile. Means is, once again, there is yellow fluid, means there is only the joint effusion. Synovial biopsy showed that thickened synovium macroscopically with histological evidence of increased inflammatory infiltrate. So only the inflammations in the synovial biopsy. So having an ESR, only extra of the left knee and having some of the aspiration of left knee joints and synovial biopsy, don't give any of the features here, alright, ankylosing spondylitis more likely. Immediately after that, my dear, the sixth step, that is examination findings, means we'll start from here. All examinations. He appeared well. He had a temperature of the 37.5 degree centigrade. An examination of his upper arms did not reveal a BCG scar. So no BCG scar once again. Risk to develop the tuberculosis. Examination of the left knee demonstrated a painful erythema joint with a large synovial effusion. So we got the asymmetrical oligoarthritis part on the respiratory system. There was some harsh breath sounds in an anterior aspect of the chest. And attending the rheumatologist requested some investigations that we already have seen. On the basis of these investigations, the patient was commenced on empirical anti-tubercular therapy. Because having a high ESR, he was reviewed 4 months later and had an ESR check, and which measured still 57. So now go up. Means the history is the seventh step. 34-year-old Bangladeshi male once again. So Bangladeshi peoples or Indian peoples are prone to develop. Yes, once again the TB presented with the 4-week history of the painful swollen knee, which he attributed to fall during a game of tennis. The knee was painful after the fall, but over the next 2 weeks he developed swelling and increasing pain, which was only partially relieved by paracetamol. He had never had a similar problem in the past, apart from feeling slightly more breathless than usual while playing tennis. Over the past 3 months, he had no other complaints. There was no significant family history except that his grandparents had both had TB. He couldn't even recall having had a BCG vaccine, but did have several x-rays in his early teenage years. So, with the scenario, the history says that the Bangladeshi and having the grandparents and the both TB and don't or didn't have the BCG vaccine. So these are risk factors for the development of the tuberculosis, no doubt, and didn't reveal a BCG scar as well. But the thing is that the TB is excluding because of these investigations. The patient was commenced on empirical anti-TB, but once again the still ESR is high, so TB is less likely the diagnosis. So what else? So ankylosing spondylitis once again is the likely diagnosis here. So what is the next question, right? What is the following test will be the most having the diagnostic informations? So diagnostic tests for the ankylosing spondylitis, once again the SI joints. Radiology means the X-ray of the SI joints, other than HLB 27 and other tests as well. Third, what investigation will be the best for his respiratory disease? The best for his respiratory disease, once again, the pulmonary function test with the KCO. Alright, I'm sorry, this is the options are not here, so you have to write down the PFT, yes, with KCO will be the, yes, the informatives for the respiratory diseases. What treatment you should start as a first line treatment for him? Yes, the NSAIDs is the first line treatment should be started. So the question is the diagnosis ankylosing spondylitis. The test, the diagnostic is for the X-ray SI joints, and then respiratory diseases. Once again the PFT and KCO. Yes. And for treatment, the NSAID is the first line treatment that should be started. Here are some of the explanations that is given why the inflamed knee joint in association with the abnormal X-ray, highly suggestive TB and Asian patient. Failure to improve the anti-TB is against this diagnosis. The talk that I already said. Young male synovitis, knee joint, ankle joints, lumbar, cervical, differential diagnosis, long list. Rheumatoid arthritis, because rheumatoid factor is negative here. Adult Still's disease can be a possibility, and cerebral spondyloarthritis, particularly ankylosing spondylitis. The absence of rheumatoid factor against the diagnosed rheumatoid arthritis. Still, disease is not sufficient to explain the X-ray abnormalities. It needs a long list of features that you will learn in the Still disease KBA file, which in this case are due to apical fibrillary well-recognized complication ankylosing spondylitis. And here a box that I'd like to mention here, the cause of apical lung fibrosis, that is also will be discussed in the chapter of respiratory system, but here I'm just reminding you the breast clasps, the name that you need to learn, my dear. So once again I'm saying reminding you to the people's right. B for benign ileosis, R for radiation, E for extrinsic allergic alveolitis, A for allergic bronchopulmonary aspergillosis, and then once again the silicosis, T for tuberculosis, S for sarcoidosis. Next, C for coal-workers pneumoconiosis, L for Langerhans histiocytosis, and ankylosing spondylitis and psoriatic arthritis. So my ankylosing spondylitis is a chronic inflammatory disorder that primarily affects the spinal joint, strongly associated with the presence of HLA-B27. 95% of all cases. Disease is more prevalent in the males than second and third decades. The exact etiology is disorder unknown. Most patients present with the sacroiliitis causing back pain and stiffness, which is worse in the mornings. There is a characteristic loss of lumbar lordosis and reduced ability to flex the spine. And asymmetry peripheral large joints asymmetry is a feature. So one of the important things that cerebral spondyloarthritis that we already learned, yes, they can cause the sacroiliitis that we learned. This sacroiliitis caused by cerebral spondyloarthritis, the peer. Remember, my dear, peer. Psoriatic arthropathy, ankylosing spondylitis syndrome. But the wow should be remembered. What I'm saying, the wow should be remembered. So make a box and write down all them together, my dear. Yes, Y for Whipple's disease and O for osteoarthritis can cause the sacroiliitis as well. Enthesopathy, yes, cause the pain in the tendons, particularly Achilles tendons, weight loss, low-grade fever, high inflammatory markers are also well recognized in ankylosing spondylitis. Some of the extra-articular complications occur in 15%. Right, the extra-articular complications can occur. The diagnosis is a clinical one, but is helped by the demonstration of sacroiliitis. So yes, the diagnosis is clinical, but the demonstration of sacroiliitis acts of the pelvis, and the demonstration of thickening and calcification of interspinous ligament, which may give an appearance of the bamboo spine. So here's the correct answer. The ankylosing spondylitis diagnostic test, information exercise joints, and investigation. There is a PFT with Casio, and NSH is the first line treatment. And another simple case that I'd like to discuss here, right? A 32-year-old man, yes, with a good past health, complained of insidious onset of the low back pain and stiffness for one in particular in the morning. So morning stiffness, back pain. Always think about the inflammatory joint pains, and always think about the ankylosing spondylitis, means the cerebral spondyloarthritis. Physical examination showed that restricted range of movement of the lumbar spine and local tenderness was elicited over both sacroiliac regions. Examination of the eyes revealed the evidence of bilateral uveitis. Lab investigations were unremarkable apart from the raised ESR. In view of the symptoms, radiographs of the lumbar spine and pelvis were performed. The question is that what abnormalities do you see on this radiograph, and what is the diagnosis? The question. In pelvis and lumbar spine, In a pelvis, that we are expecting ankylosing of the both sacroiliac joints. You see the ankylosing of the both sacroiliac joints, yes. Be very vigilant to look into the features of ankylosing of the SI joints. Partial ankylosing of the pubic symphysis as well. Yes, you see the pubic symphysis, the partial ankylosing. Loss of joint space, erosions, and secondary sclerosis of the right hip. So having some of the right hip changes. So the most important features here, the ankylosing of the SI joints. Lumbar spine, squaring of the vertebral bodies. You see the lumbar spine, the vertebral bodies tend to be squaring shaped. Syndesmophysis, yes, this is a very important point. Syndesmophysis, all right. And ankylosis of the intervertebral facet joints and ossification of the interspinous and supraspinous ligaments. So you see that lateral view of the lumbosacral spine shows the ossification of the anterior aspect of the intervertebral disc. So you see the ossification, all right, intervertebral disc. So this is the ossifications, intervertebral disc, yes. And the vertebrae are square. So you see the vertebrae and a square-shaped vertebrae. Square vertebra, we can say, and also the facet joints are ankylosed. That is facet joints. You see that the facet joints are ankylosed. There is no demarcation lines are here. So the most important part that what I have put, right, the summary talk of the SS box, that you should make a notes of SS box. Ankylosing spondylitis. So the word that spondylitis means the SI joints. Then you see the symphysis, then scoring of the vertebra, then syndesmophysis, all right. And then you see the ankylosing intervertebral facet joints and ossification. So these are the S rule that we can remember, all right, of SS box. Ankylosing spondylitis. So very typical for SI joints, ankylosing here, and also the ossification of, yes. So this is very important, of interspinous and supraspinous ligaments, squaring of the vertebra, as well as the syndesmophysis. And some of the discussion that I'd like to do, yes. The frontal view of the lumbar spine. Same patient shows the syndesmophysis at the margins of the intervertebral disc. You see, at the margins of the intervertebral disc. So this shows the syndesmophysis of the intervertebral disc. So same thing, you see the intervertebral disc, the margins having and syndesmophysis. More advanced syndesmophysis formation termed the bamboo spine. Yes, it is a bamboo spine. The spinous ligaments are also calcified and ossified, giving a total. So the circle of the three longitudinal lines together. Then trolley tracking sign, another point, the trolley tracking sign. So the talk is a very typical features of ankylosing spondylitis. The radiological features, all right. Here is also another photograph, right? The frontal view of the SI joints, once again. Another patient showing the early changes of pre-ankylosis or the sacroiliitis. So yes, the cortices of the both sides of the joints are poorly defined, loss of continuous white line, and there are also erosions, and these changes are usually better seen on the iliac side rather than the sacral side of the joint. Another more two photos, right, is given here and showing the ankylosing and also the arrowheads, the ankylosing of the facet joints and you see how ankylosis already happened. So role of imaging in the patients with ankylosing is it confirms, this is important, the clinical suspicion. That's why the XA joints, which are the most important joints that is involved in ankylosing spondylitis, determines sign, extent, and severity of the disease as well. So what is the note the summary talk last talk? Ankylosing spondylitis should be considered in young males with a chronic low back pain and the signs of sacroiliitis. Bilateral symmetrical sacroiliitis, syndesmophytes, ligamentous ossification, I am saying the ossification, articular ankylosis, yes, are characteristic radiological features. If I am saying the ankylosing spondylitis, ankylosing is one of the most important features, and as for symmetrical sacroiliitis, syndesmophytes, and ossification means the rule of as. Remember, my dear, calcification, ossification connective tissue forms a large component of this disease. So ossification, once again, that you need to remember. So summary talk, young males, low back pain, sacroiliitis. Ankylosing and spondylitis, sacroiliitis, symmetrical, syndesmophytes, ossification are characteristic features. Next, some of the assessment regarding the functional status as well. So a number of indices and scores are used in the assessment of the patients, both in clinical practice and research. The Barnes die is used, so circle the Barnes die, all right, is used to patients suitable for treatment with anti-TNF alpha therapies and to assess their response to the treatment. So the Barnes die is a Bath ankylosing spondylitis disease activity index, depending on the fatigue, spinal pain, joint pain, localized tenderness, and morning stiffness. And BAS-Phi as well, the functional index, and BAS-G as well, depending on the general well-being and also general well-being in the last 6 months, and BAS-MI, all right, that depends on the metrology index, cervical rotation, triggers to wall distance, lumbar lateral flexion, lumbar flexion, and intermalleolar distance. So my dear, you don't need to go through the details of this BAS-DI, BAS-Phi, BAS-G, BAS-MI. So these are the assessment based on what are the factors. You don't need them, but what we need basically, right, the treatment. The physiotherapy NSAIDs, we said the answer is the first line treatment. And we already learned that sulfasalazine and methotrexate, these are basically for the peripheral joints, not effective for the spinal joints. And anti-TNF alpha therapy, that is one of the important points in talk, in the last talk, is very effective. Used when the Barnes-Dye score is above the 4 despite the NSAIDs. So if you start with the SS box for the ankylosing spondylitis, so yes, the Barnes-Dye score more than 4 despite NSAIDs, then go for anti-TNF alpha therapy. This is one of the important hot topic in the 5-star topic for the exam, my dear, that you need to remember. And these are references that is taken, is given here. So my dear, the summary talk, right, the ankylosing spondylitis treatment, there's anti-TNF therapy, Barnes-Dye score greater than 4, Barnes-Dye greater than 4 despite NSAIDs. And here is the radiological features, the SS box, once again ankylosing, and as for symmetrical sacroiliitis, syndesmophyte, ossification. And last but not the least, that the box, SS box, that the rule of A, that are the clinical features of ankylosing spondylitis. So, mind that you have the knowledges that we already learned here. So we have applied very, very well. So knowledge-based application, KBA 5, and KBA means the question-based approach that we learn, that will be really, really helpful. I hope that you enjoyed, my dear. Thank you very much.